We do have a bunch of good questions coming in, so why don't we just turn right to them. And first one jumps right in with getting back to the question of RAS mutations and how we help these patients whose tumors actually do have a RAS mutation. When we lose the option of using the antibodies, cetuximab, panitumumab, what other options do we have for these folks? Are there new things coming out in the pipeline in this subset?
Absolutely. And so what I just painted for you is that this is getting to be a bigger group. So it went from 40%, now it's going to be 60%. So yeah, this is not a group of patients you just sort of lob an EGFR and hope, because there could be harm. There isn't any approved medicine. So you've got your VEGF inhibitors through lines of therapy. You've got refractory Stivarga regorafenib approved in this indication. But yes, we are developing a lot of new medicines. I've been interested in the sort of outcry for this patient population because on the one hand, we have a lot more medicines than we ever had before, even for this population, and yet we sort of feel like we're shortchanging this group. So the hope is we will identify new targets that will really get to the vulnerability of these KRAS mutated tumors and target this pathway. And there is work going on, but it's still at the research level.
Fantastic. Just a reminder to our audience, do keep sending in those questions. We do have a good amount of time here, and so we'll be happy to run through some of these. Another question sort of stemming away a little bit from the metastatic setting, but I think a good one in terms of the profiling that you've discussed. What about using profiling tools, something like an Oncotype score, to help make a decision about how you're going to manage that stage 2 patient who may or may not benefit from adjuvant chemotherapy?
Yeah, I really wish we had a good, strong profile for the adjuvant setting. Because what we really have are 3 groups in the adjuvant setting. We have the group that the surgeons cured. We have the groups that the surgeons didn't cure, but chemo will cure them. And we have the group that the surgeons didn't cure and chemo won't. But we don't know who they are, right? And so to me, that's really what I'm looking for. I want, you know, if I want to black, white, red kind of profile, because we are treating, stage 2 is a great example, where we're treating 100 people and helping 3, right? Yeah, I can give you the risk reduction number and talk you into taking chemotherapy, but I could also say that that's treatment that fails 97% of the time. So we need to develop better strategies. So Oncotype, there's Coloprint is being developed. There are others that are being developed that may in fact help guide this. But we still don't have that sort of black and white and red markers to know whether chemo's in or not. So I don't fault anyone doing molecular profiling, the Oncotype or the Coloprint. I am the US PI for the Coloprint study, so we're hoping that that new data will be better than what we have now. And remember, Oncotype for colon is not as valuable as it is for breast. It's a valuable test for breast. It can help decision making. And so some of my colleagues say, well, if this test would help you decide, let's order it. If other patients are like, I don't know, you do what you do, I tend not to. But I wouldn't fault people for ordering it.
Fantastic. So we've talked a lot about the differences and the heterogeneity of these different tumors. What about the heterogeneity of the patients that we're treating? Very specifically, a lot of these studies that you've been discussing were in an optimal population, but a lot of the patients we're seeing are not, and frankly, a lot of the patients we're seeing are in an older population. So when you start to see folks who maybe their performance status isn't great, or maybe they're clearly in that sort of geriatric population as our population is increasingly becoming, how does that modify your approach to them, or does it even modify your approach?
Yeah. Well, maybe I could go to both ends of the spectrum because, you know, we often see that 30-year-old, particularly around here, 30, 40-year-old with metastatic colon cancer, and invariably that patient will come in and say, I'm going to do better because I'm young, right? And when we actually drill down, we've done some sort of big data looks at the young patient with metastatic colon cancer. And in point of fact, they don't do any better. In fact, in some cases, they might do worse than the older population. And so we feel more energized about being intensive or aggressive in that younger population, but we may not be doing them much favor there. In the older population, particularly ones with a bunch of comorbidities, we can't, do some of these full Monty approaches. You can't give full Fox-Erie typically simply to an 85-year-old. You can modify, you can still do it, but it's not as simple. And I think value systems are different when you're 80 years old. You still want to be cured, no question that's true, but you're also maybe less willing to sacrifice some of your quality of life. So we clearly play the cards a bit differently in that older population. We don't have a lot of evidence because, as you know, most of the enrollment in clinical trials, the average age is somewhere around the low 60s, around 62 or so. And so when that 75-year-old comes in with some diabetes, with a little hypertension, maybe lives alone even, that's a different patient and a challenging patient. So again, play the chess game the way you can. That doesn't mean you can't give all these medicines. It doesn't mean you don't want to know their KRAS and extended RAS testing and that angiogenesis agents won't have benefit in that patient population. In the adjuvant setting, interestingly, the data around oxaliplatin really doesn't support its use in that older population, regardless of performance status. So I think the question is perfect. So the data we're looking at comes from a better, more idealized patient that's eligible for a clinical trial. Day in and day out, our patients are much more complicated than this. But I suspect everyone's going to be seeing younger and younger patients with this disease. There's been a shift in the population.
Okay. Getting back a little bit to the molecular profiling, and I think a really important technical question that we're faced with is one of reimbursement. As these tests are being developed, even though they're not yet entirely proven to be predictive, to be prognostic, how are we able to get insurance companies, second payers to support them as a part of our workup and management for our patients?
Yeah. No, I'm not sure we're ready to go to the building behind us and ask formal permission, because we're not, as you said, we haven't really tied the profile to an outcome yet. And that's really where we need to go. But a lot of insurance companies are covering this. And the companies that have these profiling programs, Foundation, Caris, the others, actually are billing insurance and not gap billing the patient, typically, is what you see. And so patients, for the most part, are not feeling the cost of these. But ultimately, we've got to defend ourselves down Pennsylvania Avenue and say that they're worth it. So this is where I think our next job is not to just throw the tumors out there and have them tested, but really focus on the outcomes that are a result of these. How does it affect our treatment decision making? How does it reflect that individual patient's outcome? And once we get there, I think we'll be able to defend it. Costs, of course, for these things are falling. Our ability to interpret them is also a gap. I think, I'm pretty smart about colorectal cancer markers, but I'll get back one of these profiles and not really know what to do with it. And so how we teach each other what to do with these complex results will be very important as well.
So then jumping off a little bit about that uncertainty about how to use these tests, there are a lot of them out there. These tests are very much in their infancy. We have a very good question about how you decide which test you're going to send for.
So I don't generally, because I'm not convinced any one test is the right thing, and they are different approaches. So there are some groups that are doing sort of immunohistochemistry protein analysis. There are other groups that are doing gene sequencing. And then yet another group that's doing particular targets that are only druggable for a subgroup. Others are doing phosphoprotein. So as we've thought about this as a cancer center, we're struggling with this decision as a cancer center. Many have already in cancer centers have bought onto the sequence thing. They're just doing DNA sequencing on everybody, a next-gen kind of approach. I'm not sure that's right. I'm not sure it really reflects the behavior of that tumor. Others are only measuring targets that are so-called druggable. right? So something I can act on, whereas others are doing the whole gamish. I kind of want the whole gamish, right? Because maybe I don't know now, but I think it's going to be important to build the haystack adequately for the long run. So I don't think there's a right or wrong answer to the question of which one is the best. Just know the limitations, know that the test is not, none of these tests is perfect. Mostly I would emphasize new biopsies. So a patient with metastatic colon now in third line, their original tumor from 3 years ago is sitting in that's the easy one to go after, but I don't think it's the treatment, it's the cancer you're taking care of today.
Okay, very good. So a few questions about regorafenib have come through, and I think these are important since this is a new drug that's out there. Questions about really looking at the cost of it versus the benefit that we're seeing. Do you really think that this is a worthwhile treatment for our patients? And maybe should we be thinking about, or are there studies you know about, moving it up in an earlier line in treatment?
So this question drives me crazy. So why are we valuing its 1.4 months different than bevacizumab's 1.4 months or aflibercept's 1.4 months? So maybe we could talk bigger about all of their relative advantages by these big randomized studies is in fact small. If we could figure out which patients are benefiting more than others, then certainly the benefits go up. And we kind of have a randomized clinical trial is bad in the sense that it removes our skill as a physician to make treatment decisions, because all the patients, let's say a second-line study, so patients who are on first-line treatment for 18 months are eligible, but so are patients who were only on frontline therapy for 6. And those are clearly two very different biologies now going into one funnel and being treated the same way. I would think that 18-month frontline VEGF patient would be, I'd keep them on VEGF inhibitors, where that shorter frontline VEGF, if they were KRAS or RAS wild type, might be more inclined to switch treatments. Going all the way to regorafenib, you know, I think part of our negativity about it is that we have been holding it too long, one. Second, these are patients who are now veterans. They've said the word hospice at the dinner table, right? They've had that discussion. The drug is not free because it's now a pill. They've got to go to the pharmacy and pay a copay. The drug does have side effects. Some of the patients have already been through a rash with their EGFR drug. Some patients already know about hand-foot syndrome from capecitabine, this sort of thing. And so you're having a different discussion with your patient now of value of the time. And so I don't use the 1.4 month in clinic. I use the 40%. Basically tell patients that 40% of patients will stabilize with this treatment. And that is actually a higher number than the second-line treatment the patient just failed on. Okay? So in terms of overall relative benefit, more patients are caught by regorafenib than that second-line treatment you just gave. So I don't use a ton of it, to be honest, because we're having this decision, and I have patients who decline it, quite honestly. But I do think it has its place, and we shouldn't undervalue it. Cost is an incredibly important point for all the drugs. We are pricing ourselves out of the market, and we are doing it to ourselves, whether it's use of growth factors or high-end antiemetics or repeated infusions, this sort of thing. We've driven the cost up because we're in a consumption model. There's a, let's face it, there's a not overt, but a clear incentive to consume. The more drugs we give, the more money our hospitals or our systems or we ourselves make. So as we shift from that, I do think we'll see some shift in that issue as well. The United States is supporting the pharmaceutical industry with this piece, with our higher costs and consumption. So as the globe kind of shifts, I think we'll see a shift in this too.
Great. Well, thanks, John. We have time, I think, for one more question. There's a great one that came through, I think would be a great note to go out on. Considering this vast array of oncogenes that are causing colon cancer, all the profiling that we're finding we need to do in order to individualize treatment, your opinion, are we ever going to find the cure for this cancer?
Well, so it's not one cancer. That's the first point. So I think so. I think honestly, where we're heading is smarter control over the disease with targeted therapies, giving us longer-term control. But I really do feel that we will either find the vulnerabilities of a so-called stem cell and be able to do a better job that way, or immune therapy will come in and actually emerge as a really important positive impact on our overall treatment. So I'm not giving up hope that we are heading in that direction. I think to do that, we will need to morph our current systems. The sort of steady as we go standard of care that we're giving now to most patients, we know won't cure them. We have to recognize that. And so we have to partner with our patients, we have to partner with our payers, we have to partner with our pharma partners to develop new strategies that really get to the expectations that our patients have, as the question says, they want to be cured.